Good morning, everyone. My name is Dr. Dal Zotto. I'm a surgical pathology assistant professor here. And on behalf of all the group of Surg Path, we give you welcome to this new phase of your career. And I hope that you get the most of it. And for sure, we are here and we are going to help you to be successful. This series of 3 videos that I'm going to record for you are going to be more introductory to what we do in the growth room, basically a practice kind of lecture. But I highly recommend you to review these lectures before to start the surgical pathology rotation. Many of you are not going to start the 1st of July or the first weeks of July with Surg Path. So whenever you are starting the week before, please review, go back to the onboarding material and review all the videos regarding the surgical pathology growth room. I'm going to hide myself here. And we are going to start. If we can. All right. So basically what we are going to go over in this short lecture is the understanding of the work and organization of the growth room, how it's going to be arranged your working space, and the basic macroscopic procedures that you have to follow. Also, we are going to go over a little of a macroscopic examination, gross descriptions, and all the basics. Also have some tips to taking good sections for histologic examination. All of this we are going to practice during the growth room lectures. But before to start, I always say to the residents the same thing. You are first-year residents. You are the most of you are going to start learning pathology. So this is the residency, maybe the only opportunity that you have to ask questions. So please don't feel that you are going to be embarrassed or you're going to be ashamed to ask something that is probably basic, but you are going to be forgiven the first year. So don't worry, ask everything, because after you finish the residency and then more after you finish the fellowship, you are going to be expected to know the majority of the answers for others' questions. So now is the best time to ask your questions and learn from this intense 4 years training that you are going to be through. This is a overall overview of what you do during the grossing of a specimen. This is you, and here you interact with a lot of people. Basically, we don't just process tissue. We interact with a complex social environment, or social and technical environment. So you need to know your players, your team. First of all, you are going to interact with the surgeon, sometimes indirectly, but many times directly, especially during the frozen room mornings. But your specimen is going to be your patient. The surgeon is going to take a piece of tissue of the patient, and your specimen is going to be your patient. So you are going to treat that specimen with knowledge, with care, and having in mind that you are the stewards of the specimen of that patient, of the portion of that patient. So you're going to also interact with another area of the very related to the gross room, the surgical pathology department is accessioning team. The accessioning team is the team that is going to be in charge of receive the specimen, corroborate that the specimen has a paperwork and order from the surgeon, and everything matches with the paperwork. And it's going to give basically a number, we call it the accessioning number or accession number for surgical pathology. So after accessioning gives a number, you're going to receive the specimen. And at the same time, you are going to interact with several people in the gross room. One of the group is the PA, or the PAs, is have in mind that the PAs can help you, are a very valuable technical help, but will not know the diagnostic side. You are in charge of the deep knowledge of anatomy and technical aspects of the surgical specimen. Also, you are going to interact with the faculty. Faculty on the service that you are grossing for is going to be your guide. You can page him or her as much as you want or you need. You can ask questions to them and is the basic guide. However, faculty sometimes are not present because we have other duties. So a good source of information are fellows and upper residents. The fellows, have in mind that the fellows that are coming from outside UAB sometimes don't know the entire breadth of the procedures. So I highly recommend you to ask upper residents for help and PAs. So you also are going to have your own part. You have to be aware of the basic anatomy, the technical aspect of the surgical specimens, and also your commitment to self-learning. Take the initiative, you figure out what you need to know before you receive the specimen, and strive always to improve. That is due to interaction with your own colleagues, your residents, peers, your faculty, and also reading from books. Macroscopy, your duty during the gross room is going to perform the macroscopy of the specimen, or what we call it, the gross of the specimen inappropriately, but the proper name is macroscopy. You are going to perform the gross description and take the sections, appropriate sections. So make sure that you know what you are doing before to cut a specimen. The gross description can make or blow out a diagnosis. So what we are going to teach you the appropriate vocabulary for every specimen, or the majority of the specimen that you are going to learn with the months. Know that you have one shot before the specimen is chopped. So make sure that you know the procedure. Sometimes grossing mistakes or oversight can have deleterious results in the diagnosis, in the final diagnosis. And your slides will be as good as your selection of the sections. For performing this task, we're going to go over some areas: your grossing space, your grossing procedure, and the photography. We are not going to touch this photography portion. This is going to be in another lecture. But know that photography is very important. If you don't know what to do or what you are working with, beside to ask questions, you also can document your findings with a photograph. And also make sure that you photograph weird specimens or specimens that call your attention, or sometimes none, because those cases can be potential cases for publication. All of this that you do in the gross room is going to impact the other team, which is histology. Histology is the team that is in charge of the processing, embedding, and cutting for microscopic examination, your blocks, your sections. So all of this is part of a community. So I highly encourage you to communicate with all of this team constantly, especially with upper residents, peers, and PAs and accessioning team. Let's talk about your grossing space. I highly encourage you to build a habit. Have your tools always in the same place. It helped me. I'm going to give you personal tips, but I hope that that helps. But to me, it helped me a lot to have all my table organized. I know that, for example, the gloves are on one side, the ink is on another side, and all what I need for inking a specimen is close by. The blades are in another side, and my gauze and cloth are in another side. So make sure that you organize. If you are right-handed, you are going to have your tools on your right. If you are left-handed, it's better for you maybe to have your tools on your left of the table. But be consistent, because this is probably a small thing, but it saves you time, because at the moment of start grossing, the day of grossing, you must have everything in front of you. You are not going to run or walk to another area to look for gloves or to look for the ink that you don't have, because this is going to be time consuming. You are going to spend time organizing yourself, and we need you to be time efficient. And you will see why, because you will have a lot to work with. So efficiency is key. Another thing very important that I always said is make sure that you have only one case on your table. Work one by one. Even if the day is overwhelming and you have a lot of specimens on the side of the table and accessioning is putting more and more, you just work one by one. Make sure that you have the idea that the only thing that you have for grossing that day is the specimens that you have on your table, the only specimen that you have on your table. When you finish that, you move on to the next one. I highly encourage you to review the list of surgeries the night before, because you will know what is coming. For example, if you are in breast service, breast is a very complicated service. Usually mastectomies or surgeries for breast patients have a lot of prior biopsies, more than 4 or 5 clips can be found on the same specimen, radiologic clips. So that clip means a biopsy with a diagnosis, and the radiologist and the oncologist will need to know which clip correlates with the cancer and which ones not. So you are going to need to review the clinical information and the imaging before the day start. If you do it during grossing, it's not going to be time efficient. But majority of the residents do that. But I highly encourage you not to do it, to be efficient, to finish in 2 hours the grossing, and then you can spend the rest of the day previewing or doing other tasks or studying. In the gross room, we try to follow the Toyota line of production, and this is the kind of a basics for organization. You sort your table, your different elements on your table, you set in order, you clean your table. You are going to receive the table clean from the day before. And if you gross in the morning, you finish grossing at noon, you will need to leave the crossing table clean for the resident in the afternoon that is going to use the same table. Trying to organize yourself with all the tools that you need. These are all the tools that you need. You're going to have a little bucket with soap to soak all the tools inside, and a brush that we're going to talk about later. Also, you're going to have your scalpels, your forceps, a probe, a scissor, this tool that I don't know the name, but it helps you to take thin sections, and a ruler. All of this is the basic. You can choose as you like, and with time you are going to feel comfortable with some tools. You are not going to use other tools, so you can arrange your table as you want. This is an example of an excellent table. It's clean. There are no cases in the view. The headphones are in charging. Please make sure when you finish the day, the headphones are in charging, because for the following day of crossing, you are not going to have headphones charged. So you are not going to be able to dictate your cases. You may need to type them. So that is more time consuming. No blood spots, no bloody papers. The systems are logged off when you finish. So make sure that everything is logged off, everything is clean and neat, and the headphones are in charge. This is an example of a no-no table. Many specimens are on and papers are on the table. Some of the specimens accidentally, while you are moving your arms, can fall into a garbage can that is open. Usually you are going to see in the crossroom that all the garbage cans have lids with openers at one side, which allows us prevent the falling of objects inside, accidentally falling of objects or specimens inside the garbage can. The dirty gown is on the chair, which is not the ideal place to put it. The cables are exposed, and the headphones are not in charging. So make sure that if you receive this, you report this to the accessioning team and the PA supervisor. Your grossing space. You're going to be provided with non-cutting gloves, and you are going to be provided with proper equipment, protective equipment for grossing. Your gowns, your masks. Make sure that you use eye protection. If you use glasses, you can use glasses with special lids that are commercially, and you can request this on the residency program. Or many of you are using the face shields that are a little more convenient, because you can use your own glasses behind the face shields. But on the first year of residency, you're going to receive your non-cutting gloves. Non-cutting gloves can be handled, sometimes are becoming dirty, because you're going to put your latex gloves on the top of the non-cutting gloves. So sometimes the latex gloves have holes, or during manipulation of the specimens can break, and fluids and blood can stain the non-cutting gloves. These gloves must be washed in a 110 bleach solution and let dry near the sink with your ID, with your name. If I see dirty gloves thrown everywhere in the grossroom, those will be held for 24 hours with a note and be discarded if are unattended. Every non-cutting glove has their own place that we are going to show you when you come to the grossroom. Every resident has their own name, and they put the non-cutting gloves, clean non-cutting glove, inside these baskets. One important thing before you start grossing, you are going to receive your container, some cassettes, and a paperwork. The paperwork is the physician order for that specimen. So this order will have clinical information from the patient. You have to make sure that you match the patient name, medical record number, and the number that accessioning team has put on the paper match with the container and with the number in the cassette. And also the container will have a procedure. For example, in this one, I think there is left abdomen, and it should say left abdomen in the container too. Everything has to match. What happens if something doesn't match? That is a hard stop. If the name on the paperwork doesn't match in the container, make sure that you grab the correct paperwork first before report it. And if this is the correct paperwork for this container, but the numbers are not matching, or the site of the procedure is not matching with the site of the procedure in the container, we have a policy, and the policy says that any discrepancy between the container and requisition must to be resolved before proceeding. So how do you resolve it? This is something that it goes back to the accessioning team with the cassette, with the container and the paperwork. You bring to the accessioning team, and the accessioning team has to resolve it. Until this is not resolved, you cannot proceed with this case. You grab another case and move on. This is an example, and that this is a very rare thing that happened to us one night. We found a specimen, small specimen, on the floor of the gross room. So in that case, the resident who found it did the right thing. Just when you find something that is not matching, please call someone as a witness. She went to my office. She said, she reported that we went together and we put the specimen in formalin, and with the date and the time that we collected, and to the supervisor gross table, and he took care of that. Another thing that is very common to happen is that you open the container and there is no specimen inside. This is very common. It's one of the most common scenarios, especially with small biopsies. Make sure that you check the ridges of the lid and the ridges of the outside ridges of the container. And if you still don't find the specimen, please call a colleague, an attendant, especially a colleague or an attendant, the attendant on the case. If you know that the attendant on the case is around, please page the attendant, and the attendant will corroborate that there is no tissue, and you must call the clinician or the person in the clinic to let them know that they send a container without tissue. And you have to dictate in the gross field something that you didn't receive, the specimen, and your name, your witness name, and the physician when was notified, that was notified, and when was notified. And do not discard the container. Put the lid inside, do not discard the formalin inside, and leave it in case that the clinician may want to come back and inspect the specimen. The second scenario is the rule of double identifier. Whenever you have to transfer a piece, sometimes, for example, big pieces of bone, you have to cut in small pieces. Small pieces must have a time in decalcifier. So you put that small piece in another container with the calcifier solution. So you transfer from the original container a specimen to another container that is not labeled properly. So you have to label with at least two identifiers. It can be the name of the patient and the accession number, or it can be the name, the medical record number, at least 2 identifiers, and those 2 identifiers must be written on the side of the container, never on the lid of the container, because lids can be transferred to another similar container and the information can be mixed up. So on the right side, you have a well done decal placement. This is resident wrote the date, the name of the patient, and I think that here is the number or the accession number, and they clarified that was decal and when the time that they put it in decal. So this is the correct way to do it. This is the incorrect way to do it. Your grossing procedure, then we are going to move to the resources that you have for your grossing procedure. Within the anatomic pathology, what we call the folder that we call anatomic pathology HSIS server, you are going to have the grossing manual that is called UAB grossing manual with different subspecialties. Each subspecialty will have a procedure. Within that procedure, some of the procedures involve the triage of the specimen. That means that some specimens, or the majority of the specimens that we receive here are received fresh without formalin, and we are going to do something to place them properly in formalin. So triage is the procedure. Triage is open the specimen, weight, measure, give a basic measurement, write all your documentation in the paperwork, and then place the specimen in formalin. As a general rule, if you touch a specimen, if you are involved with a specimen, you document what you did, your initials, the date and time in the paperwork. The gross description basics. You're going to be provided in the UAB grossing manual with example dictations that you can copy and paste and adapt according with your specimen. Each specimen is different. Sometimes you may need a different approach. But in general, gross descriptions should be to the point, should be well organized, and that is why we standardized the description, the basic description, followed by adequate dissection, and sometimes you can use diagrams for complicated specimen, and list the special studies that were done. Don't forget, if the specimen had a frozen section that day, make sure that you dictate what the pathologist said during the frozen section. If you took photographs, you documented, or radiograph, you documented. Always, when you finish dictating, please proofread. This is very important because your description has to have sense. It's not that we need a verbose gross description. We need a gross description to the point, concise, but accurate. The measurements that we do is in centimeters, and it must be accurate. It cannot be round up, because many of the tumors that you are going to gross, the TNM for staging, the T is the size of the tumor in a majority of the systems. So it has to be accurate. It's not the same to say that a breast tumor measures 2 centimeters, 2.0, or 2.1, because that is going to change the T or the staging of the patient. And the measurements must be in 3 dimensions, never in 2 dimensions. The exception is the hollow organs, colon, small bowel, fallopian tube. Those are hollow organs that you can measure in length and in diameter. We are going to practice, don't worry, all of this. We weight the solid organs in grams also. And here you have some precise and imprecise examples that we took from grossing books. Your grossing procedure. One of the most difficult things at the beginning of the residency is to be comfortable describing lesions on organs. We are going to practice this a lot during the first year. But basically, we follow several rules that you can read in the books. You describe the lesion, its color, how is its consistency, if it's solid or cystic, the shape of the mass or the lesion, and the borders. So in this case, you have a large bowel, this portion of large bowel with a polyp. You are going to describe a pink, lobulated, well-circumscribed, pedunculated polyp, for example. And here there is another one that is small, round, well-circumscribed, and this one looks sessile. You are going to have that vocabulary with the time, don't worry. Now I have a homework for you. You can email me what you think about this mass. How would you describe this mass following the little helper that we had in the prior slide? So how is the color? How do you think that is the consistency? How are the borders? And you're going to email me if you want. If you don't, the first day of residency, I'm going to look for you and we are going to practice this. This is another example. You can guess also what kind of organ is. Here is the tumor, the shape, the borders, the color, and the consistency. Those are the descriptions that you need to practice. That is why, if you want to email me, I will be happy to receive your answers. This is another one. Also, the organ is a clue. This organ has a kind of a white striking surface and it has little hairs, so you can guess what organ it is. And then the lesion, the shape, the color, the borders, and the consistency. What do you think? Another thing that I highly encourage you is to, when we don't remember all the anatomy and all the, for example, in my case, I'm foreign, and I don't know how to say in English all the parts of this is a ear lobe. So I don't know the different parts in English of the earlobe, so I have to Google it. So I highly encourage you to Google and be appropriate in the description. For example, this is the lesion. This is a skin lesion located in the pre-auricular area, is ulcerated, is hemorrhagic. The borders are heat up or very well defined, and appears to involve the tragus. Here is the tragus, and the incisura, and also it goes into the medial aspect of the lobule. That is going to be my cross description for this lesion. So the faculty who is on the other side, and the faculties don't see the lesion. You are looking at the lesion, you are describing, and the faculty will have the mental image of what you are seeing, reading what you are describing. So by reading, I have to have the mental image of what you are looking at during the grossing. If I don't have something doesn't match, I will probably page you and say, hey, what did you mean by this or that? So this is part of the back and forth faculty resident. At the beginning, it's going to be more frequent. And then as soon as you start getting the right vocabulary, it's going to be easier for you. Well, here is another thing that you can email me. What is wrong here in this table? Well, think about, look at the image and let me know what you find that is wrong or right. You're going to have a special hooks that for each subspecialty, if you are grossing GI that week, you're going to have a designated hook on GI to place your gown and your face mask. If they are not soiled, they can be used for the following day. Make sure that you throw everything that is soiled, or when you finish your rotation or your week, you throw everything to leave the hook available for the next resident. Is this wrong or is right? So you're going to email me. What do you think about this picture? Selecting the tissue and taking the sections. In general rule, if you describe something that you see, you take a section of it, a representative section. All lesions or findings should be sampled. Avoid undersampling and avoid oversampling. This is easy to say, but you have a guide that is your grossing manual. In the grossing manual, you're going to have what is the basic sections that you have to take for a specimen, a specific specimen. So you're going to follow that manual. If you don't follow the manual, you're going to be called by the attending, and somehow, because there is a high chance to undersample something. And if you oversample something, you are using resources, overusing resources, and histology is not going to be happy, and the attending also is not going to be happy. Another thing that you have to do, this is the famous brush that you're going to find on your table. You're going to be provided with a brush. Well, the brush is used for clean and brush. Every time that you finish one specimen, you have to brush your tools, especially the forceps, because within the ridges of the forceps, sometimes there are pieces of specimens from the prior case. So you don't want to contaminate the current case with the prior case. So make sure that you brush your tools when you change specimens. And we are going to be very attentive, observing you. How is your procedure? And if I don't, especially me, if I don't see that you do it, I will tell you, please clean your tools. Your sections must be less than 3 millimeters in thickness, or 3 millimeters, at least 3 millimeters in thickness, and of the size of a nickel. This is a basic understanding of the size of your sections. You cannot fill the entire cassette with the piece of tissue, because the fluids during processing need to run around the tissue. So the size of the specimen that you are going to put inside the cassette is about the size of a nickel. Make sure that you leave about 2 millimeters on each side of the cassette. These are examples or a no-no section. This is a too big section and too thick, more than 3 millimeters. So make sure that you cannot, you don't do this, because the histology lab may need to, but first it's going to report it to the supervisor. And second, the tissue is under processed. Under processed means that you are not going to be able to obtain a good histologic section. So this tissue must be returned back to the processing, and this is going to take approximately 24, 48 hours more than usual, and you are going to be called for this. Lastly, too many tissue fragments. When you have especially margins that you need to know the status of the margins of a lesion. If you put too many margins in one cassette, histology lab cannot embed the same, the 4 fragments or more than 4 fragments at the same level. It's very difficult for them. And we're going to see more or less what they do for you to have a deep understanding of this. But as a rule, if you have too small fragments that are margins of a specimen, please if you have more than two, don't put more than two in each cassette. For example, this is the result. Because they are not embedding in at the same level, you are not going to have exactly the margin. Here is a lacking of the section, lacks a portion of the tissue. It's an important portion because it's the margin of the lesion. So I think that I'm done with this. Thank you. We are going to practice all of this, don't worry. But it's for you to have an overview. If you have any questions, you can email me. And also we can discuss about the little homework that I gave you in the future. See you in the next. Bye-bye.